Good morning, all. Today's topic for discussion is pulp protection, and this can be asked as list the various pulp protective agents and enumerate the guidelines for selecting different pulp protective agents. So, if such a question comes, first you have to give a flow chart, and that flow chart should include introduction, pulpal irritants, effect of caries on dental pulp, effect of tooth preparation on dental pulp, importance of remaining dentin thickness, definitions, classification, various pulp protective agents, guidelines for placement of cavity sealer, liner or base, and finally conclusion. One of the basic goals of conservative dentistry is to preserve the health of the dental pulp. Most permanent restorative materials by themselves are not protective to the pulp. Liners and bases are employed beneath the restorations to serve as a barrier between the pulp and the external irritants. Now, pulpal irritants. What are the various pulpal irritants? The disease process itself, example, caries, trauma, attrition, abrasion, erosion, etc., can cause pulpal irritation. Then, mechanical irritation during cavity preparation, such as excessive heat, pressure, and desiccation during cavity preparation. Then, chemical components of restorative materials, such as phosphoric acid of zinc phosphate cement and acid etchants. Then, thermal irritation by metallic restorations, as they conduct temperature changes to the pulp. Then, micro leakage, which allows bacteria and noxious products to gain access to the pulp. This is a schematic representation of micro leakage causing pulpal irritation. This is the restorative material, and this is the wall of the cavity or wall of the tooth preparation, and this is the gap or micro gaps between the restoration and the tooth material, and through these micro gaps bacteria can enter, and through the dentinal tubules the bacteria can reach the pulp and produce pulpal irritation. Then this is a diagrammatic representation of a restoration placed on tooth, and it indicates the different modes of protection needed to pulp. That is chemical protection, thermal protection, mechanical protection, then electrical protection, and also pulpal medication when a medicament is placed over the pulp. Then effect of dental caries on pulp. Pulp gets affected by caries directly or indirectly from the bacteria, acids, and other toxic substances which penetrate through the dental tubules. Depending upon the caries progression, pulp shows different types of defense mechanisms. Decrease in dentin permeability is the first defense to caries, and it is in the form of dentin sclerosis or sclerotic dentin. Increase in deposition of mineral crystals in dentinal tubules occurs, causing narrowing of the dentinal tubules, thus causing a decrease in the permeability of dentin. Then, reactionary dentin and reparative dentin are the two forms of tertiary dentin. If you are asked what is the difference between reactionary and reparative dentin, then you must say reactionary dentin is formed in response to mild injury, such as a shallow caries lesion. On the other hand, reparative dentin occurs in response to a more intensive injury, such as a deep caries lesion, leading to the death of primary odontoblast. Next is effect of tooth preparation on pulp. First one is the effect of pressure. The pressure of instrumentation causes aspiration of odontoblasts or nerve endings from pulp tissues into the dental tubules. This disturbs the metabolism of odontoblasts, leading to their complete degeneration and disintegration. Instrumentation pressure should not be greater than 4 ounces per inch square for high-speed instruments and should not be greater than 12 ounces per inch square for low-speed instruments. Then heat production. If pulp temperature is elevated by 11 degree Fahrenheit, destructive reaction will occur, and heat is a function of RPM or revolutions per minute, pressure, surface area of contact, and desiccation. Higher the RPM or more the RPM, more will be the heat generated, and more the pressure applied, more will be the heat generated. Then surface area of contact, if the surface area of contact between the tooth and the burr is more, then there is then the heat production will also be more. That is, as the surface area of contact increases, the heat generation also increases. Then desiccation or excessive drying can result in aspiration of odontoblastic processes through the dentinal tubules, resulting in their degeneration and also leading to postoperative sensitivity. Then vibrations. Vibrations are measured by their amplitude or their frequency, that is a number per unit time. It is an indication of eccentricity in rotary instruments. Higher the amplitude, more destructive is the pulp response. Next is speed of rotation. Ultra high speed should be used for removal of enamel and superficial dentin. A speed of 3000 to 30,000 RPM without coolant can cause pulpal damage. Next is nature of cutting instrument. Use of worn-off and dull instruments can cause vibration and reduced cutting efficiency. Clinician applies excessive operating pressure in such cases, resulting in increased temperature and finally resulting in a thermal injury to the pulp. Then use of coolants. Water spray is the ideal coolant. In deep cavities, use cotton pellet instead of air blast to dry the prepared cavity. And when air blast is used for the drying of dentin, it results in desiccation and finally damage of the odontoblast. So when coolant is not used while doing cavity preparations, it can also result in excessive heat generation and thereby resulting in pulpal injury. Then importance of remaining dentin thickness. Remaining dentin thickness is the dentin present between the floor of the tooth preparation and the pulp chamber. Dentin is considered as the best insulator and protector to pulp. Therefore, conserve the remaining sound tooth structure rather than replace the lost tooth structure with an artificial material. As the remaining dentin thickness decreases, chances of pulp injury increases. Less remaining dentin thickness, more remaining dentin thickness, producing less damage to pulp. This is a diagrammatic representation. Remaining dentin thickness is the dentin present between the floor of the cavity and the pulp chamber. Here it is less, and here it is comparatively more. Thereby, pulp protection will be more in these cases, where the remaining dentin thickness is more. Then, role of the remaining dentin thickness and effect of toxic substances on the pulp. If the remaining dentin thickness is 0.5 mm, the effect of toxic substances is 25%. If the RDT is 1 mm, it is effect of toxic substances is 10%. And if the remaining dentin thickness is 2 mm, then the toxic substances effect will be minimal or nil. Then need for pulp protection. Mechanical protection during restorative procedures. Barrier to the chemical components of restorative materials. Thermal protection against temperature changes in the pulp. Electrical protection against galvanic currents. Pulp medication to allow pulp recovery in case of deep defects. Adequate seal at the restoration tooth interface against bacterial ingress. Suppose if what are the a question is asked as what are the ideal requisites of a pulp protective agent, then we should say an ideal pulp protective agent should provide mechanical protection during restorative procedures, and it should provide a barrier to the chemical components of restorative materials, and it should also give thermal protection against temperature changes in the pulp, electrical protection against galvanic currents, and pulp medication. It should also act as a medicament to allow pulp recovery in case of deep defects, and it should also provide an adequate seal at the tooth restoration interface against bacterial ingress in case of micro leakage. Then the various pulp protective agents can be broadly classified into three categories, that is cavity sealers, cavity liners, and cavity bases. Cavity sealers include cavity varnishes and resin bonding agents. Now, the definitions. Cavity sealers, these are materials that provide a protective coating to the walls of the prepared cavity. They are applied to all the walls of the preparation and seal the interface between the restoration and the tooth. Example, cavity varnish, resin bonding agents. Then cavity liners, they are relatively thin film materials that are used to cover deep dentin in order to limit dentinal tubular fluid flow and to create a protective thermal or physical barrier. Then cavity bases. The term base is used to describe the placement of materials used in thicker dimensions beneath permanent restorations to provide for mechanical, chemical, and thermal protection of the pulp. Then these are the various pulp protective agents. This one is dical. This is zinc polycarboxylate cement, glass ionomer cement, calcium hydroxide, etc. Then this is the cavity varnish. Then cavity sealers. First one among that is cavity varnish. Cavity varnish is a solution of natural or synthetic resin dissolved in an organic solvent such as alcohol, acetone, or benzene. Some varnishes also contain medicinal agents such as eugenol, thymol, or fluorides. Then placement. Varnishes are applied with a small cotton pledget or an applicator tip. The solvent evaporates and leaves a thin layer of resin behind with porosities. A second layer is then applied to get a uniform thin layer of varnish. Two thin layer applications are ideal, which provides more protection than one single heavy layer. Then the varnish can be coated on all surfaces of cavity preparations, even on cavo surface margins, as it has a better resistance to dissolution by saliva. Then functions. It seals the margins of newly placed amalgam restorations, thereby reducing post-operative sensitivity. It prevents penetration of corrosion products into the dental tubules from amalgam restorations, thus preventing tooth discoloration. It also acts as a chemical insulator by preventing the acids from cements, such as zinc phosphate, from leaching into the dentinal tubules. The disadvantages about varnishes is that varnish should not be used under composite resin as it interferes with the polymerization reaction. Then it should also be not used under GICs or glass ionomer restorations because it interferes with the chemical bond formation and fluoride release. Next is resin bonding agents. The resin bonding agents are used mainly for bonding composite resins to tooth structure. They can be used for cavity sealing also, and they can also be used in bonding amalgam restorations to reduce micro leakage. Resin cements and dentin bonding agents are recommended for indirect restorations such as ceramic inlays, veneers, cast restorations, etc. Not only to bond the restoration to the tooth, but also to seal the prepared tooth structure. Next is cavity liners. Liners can be classified as thin film liners and thick film liners. Thin film liners are further classified as solution liners and suspension liners. Thin film liners should have a thickness of 1 to 50 micrometers, and solution liners include varnish and they should have a thickness of 2 to 5 micrometers. Suspension liners include zinc oxide type 4 or calcium hydroxide with a thickness of 20 to 25 micrometers, and thick liners should have a thickness of 200 to 1000 micrometers, and example include GIC type 3. This is a glass ionomer liner. Then suspension liners containing calcium hydroxide or zinc oxide type 4 are used for pulp protection under restorations. The solution liners include varnishes that is already mentioned. That's why we are directly dealing to suspension liners. Then calcium hydroxide based liners. These are suspensions of calcium hydroxide in an organic liquid such as methyl ethyl ketone or ethyl alcohol or in an aqueous solution of methyl cellulose. Fluoride compounds have also been incorporated in some liners. Since the supply of calcium ions encourages the formation of preparative dentin, calcium hydroxide is the preferred liner in deep cavities. for indirect pulp capping and in contact with living tissues in case of direct pulp capping. Then light cured calcium hydroxide liner, they are available as single phase systems and the setting occurs by light curing. It consists of a urethane dimethacrylate resin matrix in which calcium hydroxide and barium sulfate are incorporated. It also contains hydroxyethyl methacrylate AMA and a light activator initiator system. Then calcium hydroxide liners are commercially available as two-phase systems, that is dical, and single-phase systems, calcimol LC and septocal LC. Then zinc oxide liners, they are available as two-phase systems. They are conventional zinc oxide eugenol without any modifications. The phase containing zinc oxide and eugenol with inert oils and fillers respectively. When used in deep cavities, they have an obtundant or sedative effect on the pulp. Setting reaction is accelerated by moisture and increased temperature. Then disadvantages. When compared to the calcium hydroxide liner, zinc oxide liners are weak and less rigid. It should not be used under a composite restoration. Eugenol inhibits polymerization reaction. That's the reason why it should not be used under a composite restoration, as eugenol inhibits polymerization reaction. Then does not induce preparative dentin formation. Then moving on to cavity bases. Bases have been classified as follows, that is low strength bases and high strength bases. Low strength bases include zinc oxide eugenol, calcium hydroxide. They are generally used under temporary or interim restorations. Calcium hydroxide is used also as a sub base. Then high strength bases include GIC, reinforced zinc oxide eugenol, zinc phosphate, and zinc polycarboxylate. They are used under direct and indirect metallic restorations. Only some bases are indicated under composite resins, such as GIC. Then uses and indications of bases to protect the pulp against thermal injury, such as galvanic or electric shock and chemical irritation, to withstand the forces of condensation of the restorative material, and should also act as a shock absorber. Then to substitute dentin in deep cavities. Then to serve as an intermediate bonding material between the tooth and the composite restoration, such as DAC and sandwich techniques, to prevent the ingress of bacteria and their noxious products into the dentin tubules through micro leakage. Then clinical considerations, bases should be 0.5 to 0.75 mm thick. Very thick bases compromise the bulk of the restoration and increase the potential for fracture of the restoration. It should not remove sound tooth structure in order to provide space for a base. Conserving sound tooth structure will enhance restorative support and provide pulpal protection. Base must be applied only on the pulpal and axial walls of cavity preparations to prevent dissolution by saliva. The elastic modulus and thickness of a base affect the stability of the restoration. Mismatches in the elastic moduli between the two can cause tensile stresses at the base restoration interface, which can lead to failure of either of the materials. Zinc phosphate is the most rigid of all bases, and polymer reinforced zinc oxide eugenol has the lowest value. That zinc phosphate cement, it has been the material of choice as base under metallic restorations. It has superior physical properties and provides excellent thermal insulation. But since it is not adhesive to dentin, it is not recommended under tooth color restorations. That zinc polycarboxylate cement, its advantages over zinc phosphate are its biocompatibility and adhesion to tooth structure. Then glass ionomer cement, with the development of GIC, the function of liners and bases have begun to converge. Presently, GIC is the most popular base material under amalgam, composite resin, cast gold, and ceramic restorations. The advantages of GIC include it is highly biocompatible, producing only a mild reaction to the pulp. It is compatible with all restorative materials. It has got adhesion to tooth structure, fluoride release is there, and also has adequate strength as a base material. Then sub-bases, they are very low strength cements placed below a high strength base. Their main purpose being to reduce pulp inflammation and initiate preparative dentin formation. Suspension liners are generally used as sub-base. Calcium hydroxide is the only preferred sub-base due to its beneficial effect on the pulp. Then this is a pictorial representation. If the remaining dentin thickness is greater than 2 mm, we need only a varnish. If it is between 0.5 to 2 mm, a base can be applied. And in some areas, if it is less than 0.5 mm, on that particular deep area, we can place a sub base. Over that, a suitable base material is applied. And on top of that, a restoration can be placed. So depending upon the remaining dentin thickness, we can select the pulp protective agent either to be a varnish, a base, or a combination of sub base. Then guidelines for placement of cavity sealer, liner or base. Minimum basing concept. The best possible agent for pulp protection is adequate sound dentin overlying the pulp. Hence, as far as possible, avoid removing sound tooth structure to provide space for a base. Then for amalgam restorations, for shallow cavity preparations with more than 2 mm of remaining dentin thickness, 2 coats of varnish or sealing with dentin bonding agent can be done. For moderately deep cavity preparations with 0.5 to 2 mm RDT, a cavity base of zinc polycarboxylate or GAC can be applied. And for deep cavity preparations with less than 0.5 mm RDT, a calcium hydroxide liner is placed to a thickness of 0.5 to 1 mm at the deepest portion and should be covered with a suitable cement base followed by amalgam restoration. Then for composites, shallow and moderate cavity preparations, dentin bonding agents will do. In deep cavities with less than 0.5 mm RDT, the calcium hydroxide liner, preferably visible light cured calcium hydroxide, is applied over the deepest portion. This is protected by a glass ionomer base, and following this, composite restoration is bonded to the tooth structure. Then for glass ionomers, only deep cavity preparations close to the pulp require pulp protection in the form of a calcium hydroxide liner. Then for cast gold inlays and onlays, for shallow preparations with more than 2 mm remaining dentin thickness, only the luting cement is used to seal the interface between the restoration and the tooth. For moderately deep preparations with 0.5 to 2 mm of RDT, a suitable base is applied at the deeper portion. For deep preparations close to the pulp, a calcium hydroxide liner covered by a suitable base can be used. Then for ceramic restorations, they are cemented using resin cements. Shallow and moderate preparations, dentin is sealed with a dentin bonding agent before luting with resin cement. In deep cavities, calcium hydroxide liner is placed at the deepest portion, which is protected by a glass ionomer liner. Then the tooth is etched and bonded with dentin bonding agent, and the ceramic restoration is then luted with resin cement. Then this is the guidelines for different depths of the cavity and for different methods of restoration. Amalgam, varnish or dentin bonding agent for shallow cavity, base for moderately deep cavity, and for deep cavity it includes calcium hydroxide liner and base. For composites, dentin bonding agent is needed in shallow cavity and moderately deep cavity, and deep cavity requires calcium hydroxide liner and a glass ionomer base, and glass ionomer cements requires a calcium hydroxide liner only in deep cavities, and cast gold inlays and onlays, luting cement for shallow cavity, base and luting cement for moderate cavity, calcium hydroxide liner, base and luting cement for deep cavity, ceramic inlays and onlays, dentin bonding agent and resin cement for shallow and moderate cavities, and calcium hydroxide liner, GAC base and dentin bonding agent and resin cement for deep cavities. Though the pulp has remarkable recuperative powers, all effort must be made to minimize iatrogenic insults to it. Hence, a gentle approach to cavity preparation and restoration should be employed. The importance of remaining dentin thickness must be clearly understood, and minimal dosing concept has to be followed. Always protect the pulp appropriate to each restorative material being used and ensure proper seal to prevent micro leakage. Thank you.